Take it while we got it.
And you're live.
All right, so good morning. This is not April 1st. This is April 2nd, and this is the Senate Health and Welfare Committee. And today we're looking at two bills that have come to us from the House. And the first one is H 621, and Representative Carpenter is here. So thank you for being here. Why don't you introduce yourself for the record and let us know a little bit about the bill.
Thank you, Madam Chair. For the record, Melanie Carpenter, Memorial 2 representative, and I sit on the Healthcare Committee for the House. And I'm really thankful to be here to speak about H 621. H 621 is a bill that proposes to require health insurance plans to cover diagnostic breast imaging services without cost sharing. Why is this bill important and needed? According to Komen Center for Public Policy, breast cancer is the second leading cause of death among women in Vermont. In Vermont in 2024 alone, more than 670 individuals will be diagnosed with breast cancer. More than 80 will die of the disease, and 12% of people screened in Vermont will require a callback. A callback is when an abnormal or inconclusive mammogram requires more imaging to determine the diagnosis. Unfortunately, some people who require follow-up imaging also face hundreds to thousands of dollars in cost-sharing fees. These expenses often become a barrier to care, causing many people to forego additional screening simply because they cannot afford them. H 621 works to remedy this by removing cost-sharing requirements for this type of imaging, which includes diagnostic mammography, ultrasound, and magnetic resonance imaging services, which are also known as MRIs. Finally, it is important to note that in testimony from Blue Cross and Blue Shield and the Department of Financial Regulation, they indicated that this bill would have minimal financial impact. It provides imaging services without cost share to individual and small group commercial insurance plans, and also fully insured large group commercial insurance plans. However, the bill does not apply to high deductible plans with health savings accounts. The state of Vermont does not have the authority to regulate these, and for that reason, they are not included in this bill. Our committee vote on this bill was 10-0-1 and is in full support, as it has the potential to save lives by increasing coverage.
Terrific. And what was the vote on the floor?
I'm sorry.
Was it a voice vote?
It was a voice vote.
Yeah, okay.
Trying to think. We did one where it was unanimous roll call. This was a voice vote.
Terrific. Good. Thank you. Any questions for Representative Carpenter? Very clear.
Shoot, over.
Oh,
Just don't want you to get out of here without having a challenge, right? And, you know, we all like look at these testimonies, a little trepidation. But no cost sharing, no cost impact or minimal cost impact. Is there an effect on Medicaid?
Medicaid already covers.
Medicaid already covers it. So this would essentially be borne by private. This is an effect on private insurers. Then you said something about a high cost.
High deductible. My understanding is that it's actually an IRS regulation because of the savings plan is taking in with the tax break, and so we cannot regulate that. That's actually a federal regulation, and that is the depth of my knowledge at that point. If you have more questions about that, I probably defer to our legal counsel.
That's fair. So if it's a high cost deductible,
But it's
high deductible.
I'm sorry,
Yeah.
confused. It's high deductible. If they have a high deductible, this legislation wouldn't affect that.
It would not.
Isn't that kind of where you want the impact?
It is. I would absolutely say we would love that. It's just not within our purview at this point to do that. We don't have the authority. What we do hope is that often when we make changes like this at this level, other plans follow suit because it's best practice. And we're also hoping that the federal government will look at how they are regulating and the standards that they have in place. And if they change it, then we can change much more easily. So we're hoping that this will continue to move the needle.
And you think, but I don't want to paraphrase for you, but I think you're suggesting that there's no cost impact because machines are there, the employees are trained, they're there,
Correct.
but not necessarily recognition of the fact that they might already be two block, I mean, it's already fully utilized and what have you.
That's correct.
Okay, thank you.
Thank you. Appreciate the question.
Senator
Do
Wayne.
you have any ideas, how that would be implemented if, like you could get a community clinic day when people could come in? How would you fit that in if it was available?
My understanding is that, especially with the MRIs, there's certain types of, different types of MRIs have to do that type of work, and it has to be asked for and coded for by a physician and to be medically necessary. So, because it's after an initial screening, it seems like this might be not able just to do a clinic, but just at the point of service and being able to do the callback of saying, I don't know, I had an inclusive mammogram, I need more testing, and that diagnostic work and that conversation is very individualized, so that's where I don't think it could be a clinic day necessarily, but it would provide more.
Did anybody think about, talking to a federal delegation about it at IRS?
We have been, and a lot of our advocates are right at that forefront, really trying to, actually, before I was a legislator, I had one of these experiences. And so I spoke to our local delegation here, and they're working on it nationally as well. So it's in the works, it just takes a little time. So this is something that we could do to help the people in this moment,
Okay.
and also to continue to say, this is good policy. Thank you.
Good. Any other questions? Good. Oh,
Thank you so much.
good. We'll keep you posted.
Thank you, I appreciate that. Have a good day.
Jen, let's go through this bill and then we'll, I see that there are folks in the room who might want to just offer a comment on the bill after we've been through it once.
Good morning, Jen Harvey from the Office of Legislative Counsel. We are looking at H 621 as passed by the House. This is an act relating to health insurance coverage for diagnostic breast imaging. Under our existing law, so we're in Title 8, ABSA 4100A requires health insurance coverage for mammograms and for screening by ultrasound for patients for whom the results of a screening mammogram are inconclusive or who have dense breast tissue or both. This is adding on to some onto that. It requires insurers to provide coverage for screening mammography, and it would add for other medically necessary breast imaging services upon recommendation of a healthcare provider as needed to detect not only the presence of breast cancer, but also other abnormalities of the breast or breast tissue. And in addition, insurers would need to provide that follow-up screening, not only by ultrasound, but other appropriate imaging service for a patient who has, for whom the results of the screening mammogram were inconclusive or who have dense breast tissue or both. And then it expands some of that language in the second piece, which again, under existing law, benefits provided shall cover the full cost of the mammography service or ultrasound. This adds and other breast imaging services and shall not be subject to any cost sharing. So any co-payment, deductible, co-insurance, or other cost sharing requirement or additional charge. And then there's that language was being discussed, except to the extent that such coverage would disqualify a high deductible health plan from eligibility for a health savings account under federal law, pursuant to 26 USC 223. And that's recognizing that the IRS determines which preventive services are eligible to be covered first dollar and which are not, and those that are not would disqualify a plan from eligibility for a health savings account, which pairs with a high deductible health plan.
Do we have any historical data as to why that is the case? Why this was put in place for high deductibles, anybody?
Well, I mean,
Sarah's shaking her head, yes, she knows, well, I'll go back.
right, I mean, what makes a high deductible, typically high deductible plans are less expensive because there is more cost sharing required. So if you require the plan to pick up first dollar coverage,
Haven't paid.
then there's no high deductible being met, which makes the plan more expensive, which can run into problems not only in the actuarial values for the bronze plans, but also with kind of the general philosophy behind a high deductible plan and health savings account, which get preferred tax treatment because it's paired with that high deductible plan.
Makes sense.
All right. Then just crossing out a reference to screening procedures and saying that the section applies only to procedures, because some of these would then be diagnostic, conducted by test facilities accredited by the American College of Radiologists. For the most part, the definitions are the same as in existing law, with a new definition added of other breast imaging services, which means diagnostic mammography, ultrasound, and MRI, magnetic resonance imaging services, that enable healthcare providers to detect the presence or absence of breast cancer and other abnormalities affecting the breast or breast tissue. And then finally, the act would take effect on January 1st of 2026 and apply to plans issued or offered on and after that date, on the date that the insurer offers, issues, or renews the health insurance plan, but in no event later than January 1st, 2027. This is pushing it out a year in recognition of the fact that the plan designs are already set for the 2025 plan year, and this will require some adjustment because of the lack of cost sharing.
Go ahead.
Thanks, Madam Chair. First of all, I'm assuming, although maybe I'm not right, that this doesn't cover ERISA plans.
This does not apply to self-funded plans.
Correct, okay. And then my other question is, and I unfortunately speak from experience on this one, does it include the, I'm now blanking on the word, of course, now that I'm trying to ask the question, the biopsy, needle biopsy?
Tissue biopsy, yes.
Because that is part of detecting cancer in a breast, and it's done usually during the course of an ultrasound. The breast is in the ultrasound machine, and they inject a needle into the breast to remove tissue, to then to take it to the lab to detect the.
So I'm certainly defer to the providers and insurers. As I read the language, it's specific to imaging, not biopsy.
Yeah, we should ask about that, because that's part of the procedure for detecting the cancer is taking that tissue out.
I imagine that is, my understanding that is currently covered, whether it is covered without cost sharing, I don't know.
Right, because it says, services that enable healthcare providers to detect the presence or absence of breast cancer and other abnormalities, but it's linked to the magnetic resonance imaging.
Right, mammography, ultrasound, and MRI. services.
Yeah, I mean, they use the imaging in order to find the spot to stick the needle. Believe me, it's horrible. But it's not technically imaging at that moment. So we should ask to see if that's covered.
So we'll ask about that, but that probably isn't. Theoretically, you could use some surgical techniques, needle biopsy and other techniques for diagnosis, but we'll ask.
If it's not covered, then it wouldn't.
Yeah, not.
It's not gonna. That's part of what happens during an ultrasound to detect cancer. So.
Right, I think there's different levels of ultrasound. This is, I think, has been more focused on follow-up imaging and then diagnostic imaging, as opposed to, so not all ultrasounds involve biopsy. But
Right, no, they don't, but there's a sort of series of
Yeah.
things that people have to go through, and ultimately that's what happens.
we'll put folks on notice, that's the question.
Okay, thank you.
So I'm looking around the room. If you want to comment,
happy to.
yeah. Okay, well, we'll, why don't we do that? Why don't we have Sarah come up?
Thank you. Sarah Teachout with Blue Cross and Blue Shield of Vermont. So this bill deals with a couple different things to do with breast imaging, and it is the imaging pieces in the bill. So just to be very, very clear, Blue Cross and Blue Shield of Vermont covers already did all of the services that are included in this bill. What this bill does is change the cost share for diagnostic. So currently, the IRS requires that there's no cost share if the image is prevented in future. So that's what we're currently doing. And then if it moves into the diagnostic stage, we do charge cost share for people's plans who do have cost share. So that's what's different with this. Part of the reason that this bill doesn't have a big cost impact, is it is narrow to just the imaging. Also, it, doesn't apply to high deductible health plans, which are about 40% of the plans that we sell on the exchange. And because it only applies to non-aggressive plans, fully insured plans, so that's what's keeping this bill fairly narrow, in its fiscal, impact. And the last thing on the high deductible health plans, Jen was absolutely right. The IRS gives people a tax advantage for saving money in these HRA and HSA, healthcare savings accounts and healthcare, I'm forgetting what the other one is. And so in exchange for that federal tax benefit, you have to pick up first dollar costs for non-preventive care. And that's, the trade-off. I have been working to try and get the IRS to change that rule for substance use treatment. I would say that it's not easy. So we've been working to try and get either the IRS through guidelines or Congress through legislation to find that substance use disorder treatment and medication is preventive and would fall under their existing definition. That's been a hurdle, I would say. So they've been pretty stringent on that.
And so non-preventive care, can you give me a definition in the context of this bill?
Sure, so you go in for your breast image, usually it's mammogram, at least initially. And it's either inconclusive or they see something and they want to do follow-up. So then it gets coded by your provider as preventive care, and then you have questions. So that's,
Okay,
where the decision is on that dividing line. Although I'd say right now, the current law already says that if you have a mammogram and it's inconclusive, you can get a follow-up MRI or ultrasound with no cost share. That's still falling in the preventive realm. I understand that this is difficult. The same sort of division between preventive and diagnostic falls with all kinds of cancer and other sorts of illnesses. So it's tough for people, especially people with high deductible health plans. What you're catching in this bill is mostly people who have cost share. That's a coping. That's another reason why it's not particularly sensitive.
Any other questions?
And it doesn't include the needle biopsy.
Does not include the needle
Because
biopsy.
this is just imaging.
Yeah, I just wonder what the cost breakdown is between the imaging and the needle biopsy.
Then I
I
have
tell you, the
to-
whole thing was quite expensive.
Yeah,
But I have a nervous plan, so it would count anyway.
Yeah, I would have to ask what a needle biopsy costs. And imaging is all over the map. As you know, certain facilities are extraordinarily expensive and others are relatively less expensive, I guess I would say. A lot of patients don't attempt to try and go to a lower cost site, but we do have, for example, a cost tool on our website for people who have out-of-pocket costs that they have to pay first dollar. A lot of those people are the ones who are searching for the lower cost sites of care.
Thank you. Yep. So can you provide something in writing so we put it on our page? You have that or?
I didn't, I would say that we're the only insurer that offered any fiscal impact, and so we were a little bit hesitant to be the only ones out there, putting a number on the page, but I'm
You don't
happy to
have to
say
put a
that
number,
it's
just the information that you've shared in terms of what's allowed, what's not allowed.
Sure.
And yeah, that would be very helpful.
Thank you.
And does Cancer Society wish to?
Yes.
Doctor something?
Good problem.
We get, let me just share with you and the committee, come on up. I had no idea what our time was gonna look like this morning because we had the constitutional amendment proposal on the, so I'm I'm so pleased that you're here. This helps us move right along.
Let me just start by saying thank you. I'm Mike Rolo, the Government Relations Director this morning, so I'm gonna be using my house testimony, if that's okay.
No, it's just fun.
But, we are obviously very much in support of 621. We would see this as a continuum of screening, whether or not is it preventative or not, or diagnostic. We want to make sure that when you go in for that screening, you come out with a definitive answer. I can tell you, my wife goes for her annual mammogram, and every year she gets a call back because she has that breast tissue.
Yeah.
And it's always nerve wracking, even though she knows that she's going to get a call back. And this year she got a call back because they found something. It wasn't just because it was
Right.
so it's even more nerve wracking, because then you gotta go back, you gotta wait for the results, and it's it was a cyst. And she's fine with me sharing that, so I've been clear to share that information. But I mean, it's still, and we're very blessed, the insurance that we have covers it. There's no cost share. We're okay. However, not every family is in that position. Representative Marcotte shared on the floor that his family, his wife was in the same situation, went for her annual and got a call back. And they were very happy that it was okay. And then a few weeks, or maybe it was a month later, I don't remember exactly. A few weeks later, they got a substantial bill in the mail that they weren't expecting. Now, he's the first one to admit that he wouldn't trade the results for the bill in a million years. He was very happy with the results. Very happy that his wife was safe. But he also recognized that not every family is in the same position that his, and that not every family could afford to pay that substantial bill. And that this bill was the right thing to do. And it has, as that representative mentioned, on voice vote, it was a very overwhelmingly loud, boisterous voice for the recall hearing. So the Cancer Society would urge you to support this. It was also mentioned that there are 670 women that will be diagnosed this year in the state with breast cancer, and 80 women will die this year alone in the state from breast cancer. If we can make small changes like this and help take down barriers that may seem minimal to you and I sitting around this table, but these minimal barriers are not always minimal for every single family across the state. If we can reduce these barriers and increase screenings, which I also should mention, screenings in the state are down. I mean, the study out of UVM last year, showed that screenings in the state are down. We need to do everything we can to encourage more women to get more screenings. Because eventually, when you're going to start seeing, unfortunately, when screening rates go down, you're going to eventually start seeing incident rates start to go up. It's just a reality. And unfortunately, that 80 number, which is relatively low, is going to start increasing if we don't start increasing screening rates again. So I would implore you to please take it to pass 621 to help us to bring down barriers, increase rates. So thank you.
Thank you.
So the cost of the incidence of less screening, so can that be isolated to a region, an area?
No, unfortunately, no.
Or a cost of the service?
So there's a couple of researchers at UVM at the moment that are looking at it. Of course, now that I'm saying that, they're named for escapers, but just met with them option much longer, that's the embarrassing part. There's a whole host of reasons they're looking at it. It's across demographics. There's no one magic answer, unfortunately. So they're looking into it. Hopefully they'll have some answers for us sooner rather than later, but I can't give you a definitive answer. It's not for something, but and wish I could.
Thank you.
You-
Great. Michael, I'm gonna ask you, would it help to wait until after Representative Goldman has introduced the other bill and then have you speak to both bills?
Sure.
Because I have a feeling we're gonna hear some of the similar comments. So,
And we're also
that,
very much in support of, House
That's
Bill
what I-
741, I think the number was.
yes,
So,
it is.
so
Good
I don't need to come back, you don't
Good
want.
enough.
So,
Good enough. So I think we'll do that unless there are other questions about 621. So Representative Goldman, you're here. Thanks for being patient.
Of course. Thanks for taking up this bill.
All right.
Leslie Goldman, Representative House Healthcare. Thank you for the invitation. This will probably be the easiest bill that you have to deal with because it doesn't require anything other than aligning our state law with federal regulation. If I may read from my floor report.
Please.
So many of us likely know a person who's been diagnosed with or has died from colorectal cancer. And as you know, the title of this bill is an act relating to health insurance coverage for colorectal cancer screening. I did come out of our committee 10-0, so you know that context. And I'll repeat, many of us likely know a person who's been diagnosed with or died from colorectal cancer. We've also watched them suffer terrible pain from the disease and witnessed side effects from surgery, radiation, and chemotherapy. According to Vermont Department of Health, colon and rectal cancer are the third most diagnosed cancers in Vermont and the second leading cause of cancer-related death amongst both men and women in Vermont. What's important about this is that even though it's unfortunately common, colorectal cancer is preventable by removing abnormal growths from the colon during colonoscopy before they develop into cancer. And for those whose growths have turned cancerous but detected early, cancer can be cured. And when diagnosed at such a localized stage, Vermonters have an 84% 5-year survival rate compared to an 11% 5-year survival rate diagnosed when the cancer's already spread. So it's a big deal that we detect these really early. The United States Preventive Services Task Force, which you may have heard of, independent volunteer panel, has recently changed their recommendation from 50 to 75 to 45 to 75 because of the increased incidence of colorectal screening in younger age groups. And that's why we want to align our statute with those recommendations. So I ended my floor report as I will say to you, and I'm asking you in the chamber and those listening, is your colorectal screening up to date? And for those that you care about, please inquire if their screening is up to date because you may save your own life or someone you love. So that's the bill. I can go through the sections. Section 1 just lines AVSA subsection 4100G federal law by removing specific testing and timeframe language in B1 and aligning screening for average risk individuals with USPSTF guidelines. And for an insured individual who's at high risk for colon cancer, screening will be determined by their treating clinician. You'll also see that physicians changed to clinician because screening tests may be ordered by clinicians. This is in section 1, including physicians assistants, and advanced practice nurses. And section 2 is the effective date, January 1st, 2025, plus all plans issued on or after that date as insurers offer, issue, or renew their health insurance plan, but no later than January 1st, 2026. We heard from the sponsor of the bill, Assistant General Counsel, Department of Financial Regulation, Director of Chief Counsel, Office of Legislative Counsel, Director of Communications and Legislative Affairs, Department of Health Access, Policy and Communications Consultant for Vermont Medical Society, and Director of Government, Public and Media Relations Blue Cross Blue Shield. And as I say, it passed out of our committee 10-01 and through the House on voice vote. So that sums it up. Just aligning
That
status.
was comprehensive. Thank you. So the question is, this would allow for this, the colorectal cancer screening between the ages of 45 and 75.
It takes the dates out of the
So
statute.
there's no,
Right. There's nothing, no
could be
constraints around it.
lower, could be higher.
Because of the United States, the Preventive Services Task Force changes their recommendations, we will be tied to that. So that's what's important about this.
really important.
Really important.
And just to clarify, just kind of understand, so, is this typically detected via colonoscopy or
Well, there are
blood
other,
work or?
the ultimate diagnosis is by colonoscopy, but initially you could have, stool blood testing. And if it's positive, then you go to colonoscopy. So it could start at that level. Some people go straight to colonoscopy depending on their risk factors. And there are many which I could list if you're interested, but I didn't want to throw another list at you. So.
Thank you.
It'll
It's
capture
in the bill.
everybody.
It's in the bill anyway.
Okay, thank you. It's great.
I don't want to go off too easy.
Oh, come on.
When you come into the committee, you gotta feel challenged, right? Cost, did you have a comment on cost sharing? Or
There's
not
no
cost
cost.
sharing, but no
It
cost?
really doesn't change anything because everything's pretty much aligned. Our insurers are already aligned, so that's why our statute is now aligning with what's already happening in practice.
Good, great. So Jen, why don't you just walk us through quickly? I know that Representative Goldman's already done a spectacular job. So let's do the bill together.
Put this up. Again, Jen Harvey from the Office of Legislative Counsel. And yes, Representative Bowman did a great job. We will look at the language. She described it all for you. So this is, we're again in Title 8, the insurance statutes, APSA 4100G. In the existing law, we have definitions. So change that physician term to clinician. Under existing law, insurers must provide coverage for colorectal cancer screening, including, and what's crossed out, but existing law is providing an insured 50 years of age or older with the option of either an annual fecal occult blood testing plus one flexible sigmoidoscopy every 5 years or one colonoscopy every 10 years. We would replace that with insurers shall provide coverage for colorectal screening, cancer screening, including for an insured who is not at high risk for colorectal cancer, and that term is high risk is defined below. For an insured who is not at high risk, colorectal cancer screening examinations and laboratory tests in accordance with the most recently published recommendations established by the U.S. Preventive Services Task Force for average risk adult individuals. That's the term that they use. And for an insured who is at high risk for colorectal cancer screening examinations and laboratory tests as recommended by the treating clinician here. And so that piece has not changed. And then it defines, for purposes of subdivision B2, an individual is at high risk for colorectal cancer if the individual has, this is the list Representative Goldman was referencing, a family medical history of colorectal cancer.
Yeah.
Yes.
I apologize. You may have said it, but I missed it, so I was kind of reading and listening at the same time. High risk versus not high risk, the definition and.
This is the definition.
Right.
So for purposes of subdivision B2, an individual is at high risk
Sure.
if they have one of these. That's okay.
Thank you.
So a family medical history of colorectal cancer or a genetic syndrome predisposing them to colorectal cancer, a prior occurrence of colorectal cancer or precursor polyps, prior occurrence of a chronic digestive disease condition such as inflammatory bowel disease, Crohn's disease, or ulcerative colitis, or other predisposing factors as determined by the individual's treating clinician. Other than that, physician to clinician term, this is all existing law. But basically, it's not in quotes the way we often do a definition, but by using the language of high risk, insured at high risk for colorectal cancer and not at high risk, we're sort of saying people who do fall in one of these in the list in section C, or someone who doesn't. And then under existing law and continued here, these services are not subject to any co-payment, deductible, co-insurance, or other cost sharing requirement. And in addition, an insured is not subject to any additional charge for any service associated with procedure or test for colorectal cancer screening, which may include one or more of the following. Again, this is existing law, but removal of tissue or other matter, laboratory services, clinician services, facility use, and anesthesia. And as Representative Goldman said, this one would take effect on January 1st, 2025, and apply to plans as they roll out over the course of that next year, but in no event later than January 1st, 2026. there's no need to do any changes to the plan design here because this is reflecting in state law what is already required in federal law.
Questions? Good. So who is, would you like to share with us any comments at this point? Since no one's on the agenda, Michael or
Good.
Sarah.
I can be very quick.
Good, good.
Sarah Teach out with Blue Cross and Blue Shield of Vermont, just as everyone before me has already said, this is aligning Vermont statute with federal requirements that we already follow. So this is the way our plans work today. So we don't have to make any changes, which is why you can do this effective very quickly.
You're good. And you're good. So Michael, you want to come up?
Sure, I'll come up.
You can actually speak to both bills. Sure. But start with this one, I think.
Mike Fisher, healthcare advocate. Yes, I can be very brief on the colorectal cancer bill. The HCA supports it for the reasons that have been described. Makes sense to take the ages out and to have a professional standard.
Questions? We're good.
The HCA is also in support of the breast cancer imaging bill. And I'll just say a sentence or two more about that. Boy, I wish we could have it affect a larger population of Vermonters. We have struggled with the IRS definition of preventative and are just really truly limited by that. This dynamic of the, it happens in various places in healthcare, of what is preventative and what is diagnostic and how that affects people's out of pocket, is, plagues us, I have to say. It is a challenge for consumers when they're at the doc and, especially, it might be a small number of Vermonters who really understand this stuff, but when you're watching your dimes, you're worried about the bill, it affects what you can say and what you say to your provider. And how this plays out around breast imaging, how this plays out in breast imaging is that if you go in there and say, I have a concern, I have a lump, I have a pain, I have a discharge, I have something that's bothering me, you're in the land of diagnostic. And before this bill would be in the land of caution. And it was said in this committee a few years ago, when we spent some time on this, the radiologists say, wow, we really want to know. We're going to do a better job of screening for cancer if we know the woman's concern. This concern. And so, so this bill answers that problem for a small segment of people who then have to start. I do also want to just sort of report that we spent a lot of time in the past working on this inconclusive screening callback issue. Passed it when I was a legislator, never went into effect, came back and asked the subsequent bill, do you really mean that bill? And it was worth that. It was a little more technical than that. We at the Healthcare Advocates Office used to receive a lot of calls from people who said, I thought this was covered first dollar, and I got a bill, and we used to be helping people call their carrier and work their way through. We don't get many of those cases anymore. It took a little while, but I think between carriers and the providers, they figured out how to bill better, and we don't get so many of those truly inconclusive back cases, first dollar coverage cases. So.
Thank you. Questions? This, I won't use that word. Simple word. It's always more complicated, so thank you.
Maybe I should just in full, I recognize that there are costs to these things.
Yeah.
Well,
the cost of not having this in place may be even greater, like 80 people dying in 1 year, so.
yes.
Thank you. Yes, thank you. All right. Any other comments?
No,
Sure,
jump in.
Jill.
Jill Sunhoff Karen on behalf of the Vermont Medical Society. I just want to say we support both of these bills. And I'm not gonna reiterate what Mike said. I will just say I went for my physical yesterday and my practitioner asked me if I had any lumps and I said I would never tell you. I just never would because I can't be honest with you because I do not want it to go to diagnostic. And so this would provide clarity. It would also just people can be honest with what's happening with their clinician. I think that's important. I just wanted to say that right now there's about 10 to 12% of mammograms require this callback. And so that's really what, happens for women. Do they have to, are they gonna do it? Are they gonna pay that $500 out of pocket? Are they gonna go back in? And Mike was referencing the study where we've seen a decline in screenings. And this study is out of UVM. It was published April 2023, so it's very recent. And what they said too was that kind of the ages hanging around a little bit creates confusion too. And so having clarity around the mammogram being covered would be very helpful. So our state had the second largest decline in breast cancer screenings in the nation. And that is 10,000 fewer women between the ages of 50 and 75. So you're in that high risk category. So I just wanted to give you a little bit of clarity on that study and just say that these bills, both of them will provide clarity for Vermonters so they can go in and get that zero cost share screening.
So if you have that information, if you could send it into Kiki, that helps us with our background. Because we will probably not have the luxury of time that our colleagues in the House have had on either of these bills.
Thank you.
Representative Goldman,
If I may.
raising your,
I am. One of the things that we had in our conversation was what are the implications of not screening and not making the diagnosis early and the cost to the system over time. And that was really hard to pin down because we don't know that information. But if we're treating colon cancers or breast cancers when they've already metastasized, that's a huge cost as opposed to them being detected very early. And we're hoping to prevent those downstream costs. So that's another advantage of these screenings. And the carriers can't tell us what they're saving by early detection. And that was an interesting conversation.
thank you. Do this one right over there, because we're all moving upstream. That's what we want to do.
Thank you.
All right, terrific. Maybe any questions or let me know what you would like to hear further on either of these two bills and then we'll probably move forward with some.
Can we just get a little bit of clarity on the biopsy and where the cutoff is on what it's covered and then what is not covered?
Sure, we can do that. Well, and I'm looking at,
but
I'm looking at folks who are here in the room could offer clarity about what the screening actually includes and then what is maybe excluded in terms of the needle biopsy or any other surgical type.
because it all happens at the same time.
Yeah.
So it's not like you can say, well, I want this thing, but not this thing. And still get the outcome.
Sure, but
The detection of cancer or not.
But so, from my perspective on this, if you're having an ultrasound, the ultrasound individual is, getting the picture, someone's interpreting that. If you're doing a biopsy, someone else is doing the aspiration biopsy, and then that has to go to a lab. So there are different procedures involved, so we want to know.
The radiologist does the biopsy.
Yeah, so then that's what we want to know.
Yeah.
But then it goes to the lab.
Yes, the lab
So-
does the lab work, but the person who does the actual needle biopsy is the
that person.
radiologist.
So we want to know how that sugars off. That's it.
Sarah Ticho with Blue Cross. I'm sorry, I thought I was clear. That's
And you were,
considered
but
diagnostic care. And it's not an image, so this bill doesn't eliminate the cost share for that. Although it's all covered by your health insurance.
Okay, but I guess I would like to know like where of the things that have to happen in order to diagnose cancer in a breast, what is covered and what isn't, if it's, because the images are happening at the same time biopsy is happening. And what else is not covered? Like, because if you say yes to a procedure because you think it's covered, and then there are these things that are not covered. If I were not sitting here on this committee and I heard, oh, this is all gonna be covered, I wouldn't know until after I got the bill, oh, well, the needle part of it that the actual radiologist was doing while your boob is clamped in the ultrasound machine, oh, that part wasn't covered, it was just the clamping of the boob. Just to be blunt, and so I just wanna know where the line is and if that line is something we could cross or not.
So,
So the
Any help
line
you
is
can give
the
us?
image, the line is
Just
the
the
image, and everything else, if
And
it's
so I think,
diagnostic, would
yeah.
have cost share.
the other question is, that I'm hearing here is, how does the patient know?
Right,
That's the big question. So it's not so much what's not covered here, but how does the patient know that it isn't covered? So maybe you could, and either the medical society or, insurance, you could help us understand how the patient will be informed about what is not covered.
And
That-
if I,
that really-
and I know we have other bills to get to, so I don't wanna take too much time, but the doctor who I had, the second doctor, because I had one bad experience and then had a second doctor at UVM who maybe Jill, you might be able to get, she was amazing, really amazing.
Ally?
I can't remember her name, but she's like, this is what she does, this is her thing. And it was at UVM Medical Center, she was amazing and she could explain like the procedure and what is an image and what isn't as part of what, and I'm happy to talk to you more about it if we try to get her, because she was just really good and she's just like, this is what I do all the time. And she had a medical.
So, you know, this is a good suggestion, because then she can also offer clarity about, how the patient is, communicated with. You put
Exactly.
it at the end of the sentence, but, yeah, so.
Cause I had a like little pre-meeting where they
Sure.
explained it to me and they gave me like all this information and I could, if I find it again, I could bring it in, but it was, she was just really great. So I had like these two contrasting experiences, one really, really bad and one really, really good. And a lot of it was about the communication and frankly, the skill of the provider who was doing the imaging, and she was very good.
So what we're gonna do is we're gonna call it a wrap, and then we'll continue, trying to get this information.